welcome to the Medicine Matters Diabetes podcast. I'm Eleanor McDermott. We're marking the 25th anniversary of the Psychosocial Aspects of Diabetes study group, with this series speaking to experts in the field about some key psychosocial issues affecting the care of people with diabetes. In this edition, diabetes nurse and health psychologist Kirsty Winkley from King's College London talks about why it can be so challenging for people with diabetes to initiate and continue taking their medications, and what healthcare professionals can do to support them. Let's start with a definition. I assume nobody believes people will actually take their medications 100% of the time. So what's the threshold you ideally want people to meet?
So I think we're generally talking about 80%. If people are taking medication 80% of the time that it has been prescribed, then they're doing pretty well. And I think that definition was originally proposed as part of the United Kingdom prospective diabetes study. I think that's generally what people are using. And that's just because it's come from a medication trial that we're all familiar with.
It's amazing the number of things that go back to the UKPDS.
Yes, a very important study.
So in clinical practice, do you know roughly how many people tend to fall under that threshold, that 80% threshold?
I suppose we don't know is the simple answer. And, you know, most of the studies looking to see what the rate is of people taking the medication tend to suggest that 50% of people will be taking their medication as prescribed. So it means that 50% aren't. And so that's a very interesting thought to have when you're in consultation with a patient, because, you know, I suppose most clinicians would expect people to be taking their medication all the time. But actually, if you look at the research, we shouldn't be assuming anything of the case, because clearly most people aren't taking it all of the time. And this finding is quite a robust one. You know, if you look to see the different studies that have been conducted, and most of the studies as well, you know, they're looking to see whether people have actually taken their prescription and got the medication. It doesn't necessarily mean they've actually taken it, but we know that the prescription has been issued. But we don't, you know, unless you're with somebody all the time, you wouldn't necessarily know if they did actually take the medication or not. So I think, you know, we have to think about people taking it 50% or less of the time. And people might not want to tell you, and because they might not want you to have a bad opinion of them for not taking it, which obviously leads to problems later on.
How do you think you can encourage people to discuss it in a kind of, you know, non-judgmental way?
I think from the health professional's point of view, having that idea in mind that more than half the people that you're actually seeing when you have a diabetes clinic are probably not taking the medication. I think that sort of can change the way that the consultation goes, because you're not expecting everybody to take their medication all of the time. And we know that the reasons behind that are really complex. So if you are aware of the fact that most people, well, 50% of people aren't going to be taking the medication, then you're going to have a slightly different conversation with the person in front of you, because you can be a bit more open with that person and just try to get to where they are in terms of taking their medication and what their reasons are for taking it or not taking it. So I suppose it comes down to the relationship always with the person you are trying to support. So I think if you have the time and you're not rushed and you have maybe met that person before and it's somebody you've continued to have a relationship with. All of that helps, but obviously that doesn't mean to say that that can be possible in every situation. I think diabetes nurses are quite well placed to have some quite open conversations with people about their medication and whether or not they're taking it. And also within type 2 diabetes, for example, it's if somebody's not actually taking their medication, if you assume they are taking it and their diabetes control has got worse, then you're often in the position where you want to intensify their treatment. And that will be slightly ridiculous or potentially dangerous if you're assuming they're already taking the medication that's prescribed. So without openness within the consultation, there can be some detrimental consequences for the patient. We know that not all health professionals are very good at having honest and open conversations with people with diabetes. Many are, but there'll be some clinicians that find that quite tricky. So sometimes maybe a guide to managing consultations might be helpful. And for other clinicians, they may just be naturally more psychologically aware when they're having a consultation with the patient. And some people will just have that as an additional skill set. I think we should be highlighting the problem of people not necessarily taking the medication all the time, and at the same time offering tools for helping to improve the consultation. But yes, I think longer term for the patients, we need to be thinking about how to support them long term, because this is a massive problem, really. And there may be different levels at which you can intervene. So there might be some system levels, but also there's going to be some patient levels, health professional levels. There are different ways to intervene to try and improve the use of medication.
I do some work with a professional development coach from time to time, and we had her in on a webinar that was about treatment adherence, although this was growth hormone in children. And she came up with, when you're asking patients about, well, families in this case, about adherence, you don't say, have you been taking all your medications? You just say, how many injections do you reckon you've missed this past month? Just to make it sound totally normal.
Yeah, I think that's a really good way of doing it. And for example, just saying we know that most people don't take all their injections. How many do you think you've managed in the last couple of weeks? Yes, that is a good technique to have, and it avoids the blame culture, which must be really awful. That people come to see their diabetes health professional and feel that they're going to get told off. So yeah, it's a good way, it's a good strategy, isn't it, to try and get people to open up and actually tell you what's been going on.
You alluded early to there being sort of complex reasons for people not taking medications consistently. Can you outline our current understanding of what's going on?
I think the reasons can be so complex for each person, and it will depend very much on that person. For some people, it could be that they feel like they've failed, that they should be able to manage their diabetes, for example, type 2 diabetes, without medication. And it's a question of willpower and losing weight and eating healthily and exercising. And they don't really need the medication because they've never really given it their best shot in terms of trying to control diabetes with lifestyle. So often that can be a factor for many people, that they just really feel that they need to have one last try at lifestyle before they start taking the medication to lower their blood glucose levels. And I suppose there's stigma attached to taking medication, or the issue of dependency people don't like. So these are all sort of common reasons. But yeah, I think it's very complex for each person. So without finding out really or having quite a deep conversation with somebody, you're never going to know. And, you know, if somebody has to have an injectable therapy or insulin, then there are even more reasons why it could be quite difficult for that person to take that medication. And I suppose the two biggest reasons around insulin is hypoglycemia and also weight gain. So I think if people experience hypoglycemia when they start insulin, it's a very scary thing to experience. And most people who have type 2 diabetes who start insulin obviously get very upset about putting on weight. In terms of insulin as well, I mean, it's quite well documented that many people associate starting insulin with onset of diabetes complications, because most people get their information about diabetes not from health professionals but from other sources, whether that's family, friends, the internet. And it used to be quite common that people would talk about, oh, you know, my grandma started insulin and then she had to have her foot taken off, you know, or had an amputation. And that's quite a common belief among people, and often the reason why people don't want to take insulin. Often is the side effects as well, because we have to tell people about side effects. It's very important, but the whole list of side effects can be very off-putting for people. So I think there seems to be a very long list often of reasons not to take the medication, and perhaps people are not necessarily focusing on why they should take it.
Do you think the reasons to take it are sufficiently compelling in a way, because they don't make you feel better, they just make your HbA1c go down in the short term, I mean?
I think that's part of the problem, isn't it? And I think that's, you know, not just for diabetes medication, for other medications such as antihypertensives, for example, or, you know, statins. Unless you're monitoring your blood glucose levels or your blood pressure levels, then you're not really getting the feedback that you need to tell you that something's working. And for some people, you know, if their blood sugars are very high and they've been going up very gradually, yes, of course, they're not going to feel unwell at all. So if they take the medication, they may not feel any different to when they don't take the medication. So we need to be able to convey in a very positive way what the benefits are to the person with diabetes, as well as taking into consideration all the disadvantages to taking the medication. So that's where the decisional balance tools, listing the pros and the cons of taking medications, can be quite important. And, you know, in terms of self-management of diabetes long term, that could be something that you do every time you see a person with diabetes. But often, I suppose, within a consultation, you have competing demands. You're not just thinking or talking about one thing. You might have to actually talk about lots of different things other than medication sometimes. I suppose the one thing we haven't really discussed is that we haven't really talked about how a person's sort of psychological status might affect whether or not they take medication. So I think I've been talking generally about people who aren't necessarily anxious or depressed, and that's having an impact. Whereas I think if somebody is sort of anxious or depressed, and that's maybe an additional problem, and that's affecting whether or not they're taking medication, obviously we need to think about how we support that group of patients, because, you know, they may need treatment for depression, for example, and then treating the depression may then help them to self-manage their diabetes better. So we need to be mindful that anxiety or depression are going to affect people's ability to self-manage diabetes as well.
And do you consider diabetes distress as part of that, or as distinct from that?
Yeah, I think diabetes distress is part of that, and there may be interventions that could be beneficial for somebody who is feeling completely burnt out by their diabetes. And maybe one big factor for them might be the burden of medication taking. So that is an area where we perhaps need a bit more research, actually, looking at diabetes distress and the relationship to medication taking.
What do you think can be done on a day-to-day basis in these rather time-pressured consultations to support people to take their medications consistently?
I think you've always got to ask people about their medication taking. I think you can't assume basically that people are going to be taking the medication, and to try and encourage people to talk about their experiences, because if somebody doesn't want to take that medication at all, you need to find out. It may be that there's another option to explore. It may be that they need more time to think about whether or not they might take it in the future. And I suppose we need to be thinking about where they are, because for some people it might be having a conversation around starting a new medication or insulin or an injectable therapy. For other people it might be more about, how do we help that person to continue taking this medication, because some people don't like to feel that they're reliant on something or dependent on it. And often the question I get in clinic is, how long do I have to take it for? And that's when you're starting a medication or supporting somebody with diabetes to start a medication. As a health professional, you're not thinking about stopping it. This is something that you were expecting that person to take now for the foreseeable future, which is quite an interesting thought, that this is like a course of antibiotics. You're only going to have it for 2 weeks or a week or 3 days.
If only it were that simple.
Yeah, and actually psychologically it must be very difficult, because I've never had to take a medication forever, and psychologically that must be quite hard to think that actually now I do need this forever or something like it forever.
What other reactions do you tend to see from people when they learn they have to start a new medication?
Most people will tell you that they are on too many tablets anyway. Often when you're starting insulin, a lot of people assume that you're going to stop their tablets, which isn't necessarily the case. So yes, there's often quite a bit of disappointment that if you're starting one medication, you're not going to stop lots of other things. So people do get very upset about the number of tablets they're taking every day. And obviously, for type 2 diabetes, that's going to be quite a few other things. And generally, people will be taking antihypertensives or and a statin. And then, of course, they might have another medical problem, which means they have to take other medication as well. So, yeah, it must be quite difficult actually physically taking lots of tablets every day.
And what about continuing taking all these tablets in the long term? How do you support them to do that consistently?
Again, I think most clinicians are probably assuming everybody's taking them long term, and we don't necessarily know if that's actually happening unless you have the conversation and find out. You can look at whether somebody's picking up their prescriptions on a regular basis. You can look at their medical record to do that. But yes, it may be that somebody's stopped taking a medication and you wouldn't necessarily know. And it is a problem for people taking insulin. We know that quite a few people will stop taking insulin at times or have a little bit of a holiday from insulin. So I think the main way you would pick that up is really just measuring HbA1cs and then trying to find out what was going on or what's happening at the moment. And we probably do need more sort of research to find out, how we can help people continue with medications long term.
What else do you think is the most important research needs at this particular moment in time?
I mean, I think a lot of the research at the moment is probably focusing more on when you're starting a new medication. So, for example, if you're starting insulin, it's a good opportunity to talk about the advantages and disadvantages of that medication for that person. But I suppose it's further down the line, it's what should we be doing to support people long term, because there will become transitions later on, and it is quite tricky sometimes, because you have to balance there's a lot of knowledge and skill often in self-managing diabetes long term, because often that can get more complex the longer somebody's had the diabetes. So I think the way I see it is that, we can support people when they start taking insulin, for example, because this is quite a good example, and talk about what they need to know in terms of how to do the injection. They need to know quite a bit about insulin, about how it works and how to inject themselves. And we would normally talk about titration of insulin, for example. And the research that I've been doing is focusing more on people's psychological needs when they start insulin as well. So not just talking about, what they need from a safety point of view, but also, how they feel they can manage it themselves, what are the advantages and disadvantages for them, how they can use this sort of transition point within their diabetes as an opportunity to make further changes to improve their health, if that's something that they've identified that they want to do, to try and, I suppose, make this transition a very positive experience. So that's the research that I'm currently conducting. But later on is perhaps where they may need another intervention to try and keep them on track, but also perhaps to prepare them for further intensification, because there's an awful lot of information, I suppose, to give to people when they start insulin. And I think almost you need a good maybe 18 months, 2 years, or, a bit of a plan, a long-term plan for people, and to think about, I suppose it's further intensification, prepare people for that as well, so that when, their diabetes isn't being well controlled just with one injection of insulin per day, that they know that they may need to have insulin at other times of the day as well, so more than one injection per day, and to be psychologically prepared for that, so that they can think about actually what's important is having good glycemic control and being healthy, rather than getting too caught up in, it's had to change again and that's my fault. It's not their fault, because this is just something that happens with diabetes, that often you need to intensify the treatment as long as you've had the diabetes. So yes, I suppose that's what I would like to be able to offer, is more of a longer term program for people to help them with medication for longer, and to support people so that they don't feel that, if they stop taking their medication for a reason, that they feel they can be honest. And, there might be lots of different reasons why a particular medication is just not working anymore, or that the burden of taking so many tablets has just become really, really difficult, and to get some honest and sort of practical help when they need it.
Thank you to Kirsty, and thank you for listening to this podcast, produced by Medwire News for Medicine Matters Diabetes. Please subscribe for more, and don't forget to visit diabetes.medicineMatters.com for news, expert opinion and practical advice about caring for people with diabetes.